Welcome, everyone, to another brand new episode of the Preventive Medicine Podcast. It has been a while since we've talked rehab, training, injury, and all those kinds of things. And that is pretty important when it comes to preventive medicine because training is kind of one of the cornerstones or foundations of preventive medicine. And today's guest, we're definitely going to be talking a lot about that. Our guest today is an absolute beast. If you check her out on Instagram, which will be kind of down below in the show notes and in the YouTube kind of comments down there, check out her kettlebell videos. And that most recent video she posted, absolutely nuts. She's super strong. This is Katie Dabrowski. She's a physical therapist, a doctor of physical therapy. She got her doctor of physical therapy from the University of Miami. She is a certified strength and conditioning specialist. I always mess up when I try to say CSCS. She's also the co-founder of Old Bull Athletics, which once again, if you're not following, highly recommend. Great content. And then she's also an adjunct professor in the Department of Psychology at Nova Southeastern University. And fun fact, I was just telling her before this, I found that out from a Rate My Professor rating where she's 5 out of 5. So fantastic. Welcome to the show, Katie.
Thank you so much. I'm happy to be here talking about like my favorite stuff in the world. So I'm looking forward to the conversation.
Excited to get into it, but first, our intro. Overcoming saber-toothed tigers and woolly mammoths, we must now face a new enemy, ourselves. With the rates of diseases such as heart disease, stroke, diabetes, depression, and many others ballooning, we must find a better solution to these modern epidemics. Welcome to the Preventive Medicine Podcast. We believe in building a foundation of health by means of prevention so that you can build the life you want and find fulfillment with no barriers. Hear from experts around the country on how to take your health into your hands. Take control and build a foundation of health for the life that you want to live. And now, here's your host, Raghav Sharma. We hope you enjoyed the show, and if you do, please don't hesitate to subscribe and like for all of our future content. I saw you jam into that background beat right there. It's catchy, isn't it?
I was jamming.
That's fine.
Yeah, I was jamming.
I caught you jamming over there. I made that beat, or I didn't make the beat, but I made that entire thing 6 years ago now. It's getting out there. I might need to update it.
It's a classic now. You got to keep it. It's a classic.
Anyway, welcome to the show. Our first question for every guest is, number one, what does preventive medicine mean to you?
Oh, I love that question. Preventative medicine means to me being proactive about our health instead of reacting to things that happen down the line. It means to me taking care of our bodies in ways that we kind of think for the future and not just right now. And it's very like all encompassing, not just what we think of maybe traditional medicine. It can also be things like what we're talking about today, training, finding things that you love to do, doing things that are for you. All of that I think is encompassing in preventive
Definitely.
medicine.
And the way that it seems like you kind of talk a lot about that or kind of display it as through Old Bull Athletics. And based on looking at your Instagram, Old Bull Athletics Instagram, that's kind of what you live and breathe, it sounds like. So number one, what is it? How'd you come up with the name? Because it's a little bit of an odd name kind of, but what is it?
Yeah, so Old Bull Athletics, we're a hybrid strength and conditioning and rehab facility. We have 3 locations in the Miami area. And kind of our whole goal when you walk into Old Bull is we would want somebody to not really know if somebody was there doing training or rehab. We firmly believe that training and rehab exist upon the same spectrum. And just kind of the lens that we're looking through is really dependent upon what somebody is presenting with that day. So our whole philosophy is meeting people where they're at, kind of on that spectrum of training and rehab, and helping people realize that they can do much more than they thought was possible. We kind of want to be that place where when you walk in, it maybe looks intimidating because there's a lot of big weights everywhere. And maybe people don't think that they belong necessarily right away because they're not used to that type of setting. But as soon as they realize the vibe and just that we really are all about helping everybody feel like an athlete, people start to realize like, hey, I think this gym stuff is for me too. The name, so Frankie, my business partner and the original founder of Old Bull before we partnered, he came up with the name, and it has kind of 2 meanings. So Old Bull meaning like wise and strong. So old, wise, bull, strong. We take the wise approach to strength training and rehab. Then kind of a secondary meaning, there's a lot of like young bulls in the fitness industry, kind of just trying to do like flashy stuff, stuff that maybe goes viral. We're very based in the foundations of really good like principles of exercise physiology. Like that's really our bread and butter. So that's Old Bull in the industry.
I love that. And I think it should be viewed that way as well. That's kind of how I talk to my patients on a day-to-day basis about it. Hey, we'll do some like kind of exercise right now, but I really want you to transition that to training at some point, because this isn't just like a one-stop shop. In my world, when patients come to see me for back pain, they're seeing me for, hey, let's try conservative treatment. That doesn't work. Let's go to injections or whatever it may be. I talk about it like, hey, this is the basis for everything. Once you're done with the rehab portion of this, you're still going to be training. On top of that, if I need to do an injection or something else, and that's where we're at. So I absolutely love that philosophy. How'd you come to view it that way? Was that because you were a former athlete, or is that just kind of how you were taught, or where'd that idea come from? Because it's kind of niche.
Yeah. I think I kind of think of it as just like small collections of all of my experiences throughout life that kind of led to this overarching ideology. Yeah, I mean, my background before I ever really became in this industry, like I loved movement as a kid. I was obsessed with movement, and my family owned a marina growing up, and I was just doing like cartwheels on boat trailers and treating it like my own little gymnastics backyard, and just got really into that. So I think that's a big reason, just like my love for movement from the get-go. And then, yeah, as I got into school and I fell in love with science and fell in love with neuroscience in particular, that's what I studied and was in the research world for a while before going to physical therapy school. I just started to see that, I think I can kind of like blend these worlds together, and science and exercise science and neuroscience and my love for movement. And yeah, I'll be honest, in PT school, we're not really taught that much of this model. It's a little bit different than the model that we're taught in school, the more insurance-based model being very like impairment focused, instead of kind of our model is a lot more of like highlighting people's skills and then also leveling them up in the things that maybe they're not as skillful in. And it just kind of naturally evolved into this model. And my business partner, Frankie, feels really similarly. I think it's just like a collection of so many things that we've experienced, each as he was a college athlete as well. And just over and over again, I think seeing the gaps in care that we experienced as athletes, that I experienced in internships as a PT student, and was kind of like, I don't really think this is it. Like at first, I honestly thought I maybe made a mistake, that I didn't know if I made the right call for my profession, because I just didn't align with what the models that I was being exposed to were all about. And I've been, I consider myself kind of like a trainer and a coach first who became a PT. And it just didn't make sense to me that, if progressive overload is the hallmark and the gold standard of training, how is it not in somebody that we have even bigger goals to chase in terms of coming back from pain or injury? It just didn't make sense that I wasn't seeing that in the types of settings I was exposed to.
I think that's really neat. And I think that is definitely a great mindset to have. And it's a similar mindset that I share. But unfortunately, I don't think a lot of patients do share that. What I experience in clinic is patients come in, they have an injury. Let's say their hip hurts. Maybe it's hip arthritis, whatever it is. They go to PT and they're, all right, I'm done with PT. Does it take a special kind of patient with that similar mindset? Or is that something that you can kind of help patients develop that mindset? What does that look like to shift that mentality from kind of, we're in rehab, now we're training?
Yeah, that's a good question. I mean, I think it definitely, we tend to attract a certain type of client who maybe is already a little bit bought into that mindset, potentially. However, I will say, especially when we started the business, and this was, Frankie started the business in 2015. I met him in 2019. And that's when we really brought in more of the physical therapy side. And that was definitely a time when non-insurance-based physical therapy was very rare, and a physical therapy facility just looking like a gym was quite rare. So I kind of felt like I had to do a little bit more convincing in the beginning of why this method works and what we were so passionate about and how we could help people. A really cool thing as we've grown is we're getting people coming to us now because of how we do things instead of maybe in spite of them. Like they're seeking out this type of care. And I do really think if you want to be in this type of setting, while you might attract clients who are interested in it, I think part of our job is to help make fitness more accessible to everybody who walks in the door. I think people look at a place like Old Bull and assume that maybe we only see like high-level athletes. That could not be farther from the truth. Our population is general population. I would say the average person I see is somebody in their 40s or 50s who wants to keep playing golf or who wants to keep hiking on trips, not necessarily a collegiate or a pro athlete. And I think part of our job as clinicians in this type of space is to do everything we can to make people realize that they deserve this level of care too, that they deserve what it feels like to enjoy training and fall in love with the process. So I think a lot of it is on us as providers to make an atmosphere that's really welcoming. That's a big goal of ours at Old Bull. Like, we really treat everybody as a family, and we want people to realize, like, this isn't just for meatheads, like, this is for everybody. But it's challenging. It's in a sad way, it's unconventional. I wish it wasn't, but it's a little bit foreign to some people who aren't as familiar with, oh, like, movement is our treatment. Like, are you sure? This is different than what I expected. So it's been very interesting to see the evolution of, kind of like the scripts I had prepared before. I was like, this is why what we're doing works, and here's the data, and here's the statistics. And now it's been very exciting to get people coming in because they're looking for exactly what we're providing, which is super cool.
Yeah, I mean, a lot of the proof is in the pudding. I'm sure you're experiencing as patients kind of go through that process. They realize, hey, this is actually what I should be doing. One of the things that I want to ask about is that mindset shift that you see in patients during that, because a lot of patients, when they come to you, they're probably thinking, hey, I'm going to cure my injury, I'm going to be done. How do you kind of help shift that? And what does that shift actually look like for patients? Because that's something that I see on a daily basis that I'm trying to help instill as a little bit. Obviously, I don't get as much face time with my patients as someone like a therapist or a trainer would. So I try to start that little switch of, hey, this is something you're going to be doing, but what does that switch actually look like now that I'm talking to someone that helps make it happen?
Yeah. Well, first of all, I love that you're initiating that conversation. Like, I wish we had more collaboration.
Don't give me too much credit. It's only, I don't have that long with patients, only a little bit. It's like 2-3 minutes.
It makes a difference. It makes a difference. It really, really does. And we see that and we feel that as PTs. I think the best thing that we can do as providers is, like, set the stage immediately, like, early and often. So as soon as I meet with somebody, and as soon as somebody on our team meets with somebody, we make it really clear what we're all about. And we'll often say something like, as you can see, this looks a little bit different than maybe where you've been before for physical therapy. Our process is all about helping to make sure that you can not only get back to what you wanted to do, but do even more than you thought you could do. And that involves this kind of model of we're doing a lot more movement. We're doing things that look a lot more like training. And I think if you set the stage very early and explain people up front what your process is, that helps. And then kind of like sprinkle in reminders throughout the fact. A lot of it too, it is kind of, it's a process of almost undoing narratives that people come in with that really make them fearful of movement, or unfortunately things that maybe previous providers have told them that aren't really rooted in evidence and can be creating a lot of like fearful narratives about lifting and pain and movement. So we're kind of slowly undoing some of those narratives, but over time, I've really changed the way I do that. And I used to try to just explain and tell people why what we're doing is important. And now, honestly, I've shifted my goalpost a lot to, if I can create a really positive experience with movement for this person, that's going to change their mind a lot better than me just telling them over and over again. So we make it fun. We try to get pretty much right to movement when we can, to lessen that idea in their head that there's this big barrier to training. I think one of the big problems that we face in the world is there's obviously, physical activity levels are quite low. And there's a lot of underlying relationships between, just general poor metabolic health and people's experience of tendon pain, people's experience of arthritis, people's experience of different common like musculoskeletal conditions that just by adding in good training can really clear a lot of that stuff up. Oh yeah. I think a lot of what I've really shifted my mind on is just like trying to lower that barrier to exercise as soon as I possibly can. If I meet somebody who's really scared of training and we don't really get to movement that first session, I've kind of missed my opportunity to show them like, no, you are ready to move. This is safe. So it all comes down to how can I lower the barrier to entry for people to start engaging in exercise? How can I decrease some fear and maybe decrease some of those like nocibic beliefs that they might have come in with, and then just make it fun. Like at the end of the day, it just needs to be fun. That's really what makes it stick.
When patients are coming in for you, when you're talking about getting them started with movement right away, are you talking about starting with things like the basic McKenzie exercises or whatnot? Or are you starting them to do some like actual exercises? Because from our perspective, I think our practice does a really good job of being like pretty specific on our like PT scripts of, hey, we want blah, 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 blah. But a lot of scripts are just like McKenzie, low back pain,
Yeah.
stuff like that. So how are you actually starting these patients on movement? Does that mean they're squatting day one, or what are they doing on day one?
Maybe. It depends on what they're ready for. So we don't actually have any standardized assessments and things that we go through with every single patient, since every patient presents really differently. You can have patterns, and pattern recognition is huge, but a lot of it is really like in real time meeting the client where they're at and making sure that you're doing things in a way that are progressive and gradual, that's aligned with what their tolerance is. My big thing that I think of is, like, I kind of have two constant goals when I'm working with somebody. On one side, I want to find all of the things movement-wise that don't really trigger their symptoms and make them feel good. And I want to give them those as like, hey, this is the stuff we're going to really beef up, and things that you can feel very safe and confident doing. Then, of course, I want to find the things that they have a hard time with. And I want to find day one, to the best of my ability, an entry point for those movements. So if somebody who has experienced back pain and they're fearful of deadlifting or hinging or bending forward, doesn't necessarily mean I'm going to be making them deadlift with a bar day one, but I am going to find a way to start like finding that entry point to stress the tissues that one day are going to need to be stressed for a deadlift. It kind of comes from a philosophy of like two things. I need to start developing like physiological adaptation and physiological ability to tolerate stress on their tissues and actually their muscles and their joints and their tendons and their ligaments. But I also need to psychologically start building up their tolerance too. So if my message for somebody with back pain is that deadlifting is safe, if I wait way too long to start making us do things that kind of start to look like deadlifting, I'm kind of adding to their fear, and I'm making them still think like, oh, but I'm not ready yet.
Yeah,
So
we're like building up to something big, but
yeah,
reality it's
exactly. And
not.
that can stress people out more. Like, I don't want people to feel like it has to be so stressful. So that first day, I'm talking and having a conversation. I have the luxury of having an hour with somebody. So we're diving into their history, diving into their exercise and programming background, which gives me probably the most information in an evaluation once red flags are ruled out. And then we start exploring movement. And that's how I describe it. I don't say testing. I don't say assessments. That freaks people out and makes them think they're under a microscope. And I'm going to tell them like everything that's wrong with them. We're going to explore movements. We're going to find stuff today that feels good, that we can keep pushing. We're also going to find stuff today that maybe makes us realize, oop, we're not there yet. So we're going to gradually build you up.
I want to kind of two things. One is you mentioned kind of general metabolic health, getting people moving in general. If I could have all of my patients just do that in general, I think probably like 75% of my job would be done, because a lot of these patients come in with any sort of pain. Number one, it's an intolerance to movement. And number two, it's just an intolerance to just kind of pain in general. And I think being an athlete yourself, and not really an athlete, just power lifter myself, an ultra runner, not consider myself an athlete, but just building up tolerance to movement, all those different kinds of things teaches you there's different thresholds of things pain wise. So I think that's a fantastic approach there. Second wise, you addressed some like care gaps that you were mentioning earlier. And if I could send all of my patients to you, I would definitely do that, because it sounds fantastic. But unfortunately, most patients who are coming are looking for some sort of insurance-based model, because things are expensive. Obviously, there's gaps. They're not being able to pay for a lot of these things. So kind of with that gap, how do you kind of collaborate with physicians and others to try to get that bridge so more patients are doing things like you?
Yeah, absolutely. So I think of it in a few ways. Like, I want to be very clear that I don't think non-insurance based PT is superior automatically to other types of providers. It affords us more time with people, and it does change how our model can look. But I understand that that's not possible for every setting. I think some good things to consider are, if you can find providers who are as close to one-on-one as possible, so they have more time with you. If you can find providers that have more equipment in their space than just treatment tables. There's a ton of phenomenal places that accept insurance that have those offerings too. So I think that stuff is kind of what I'm getting at too, because I understand the pushback of people saying kind of like, oh, well, if I can't go somewhere with insurance, then I guess, does that mean it just sucks? And that's not the case. I think if you do a little digging and find those places with those qualities that I mentioned, that helps a lot. We also have a nonprofit that provides scholarship opportunities for people who might not ordinarily be able to afford our services. We also offer a lot of different ways to get in front of people in that might be more cost effective, like group offerings or workshops or other ways to kind of get in front of the community that might not only be a one-on-one session with us. And we also have really good relationships with other physical therapists who are insurance providers. So potentially, for an example, if somebody has to have an ACL reconstruction, it would be really wise for them to exhaust their insurance benefits somewhere where they can use that and not have to pay out of pocket. And then potentially wherein it becomes a little bit more where the setting does matter a lot more for return to sport. So you have access to the appropriate testing equipment and things that are really going to get people back to sport. That's where we can come in and bridge that gap. We also offer, hybrid models of being able to come in and see us, but also follow a program. Because we have so much time with people, sometimes I don't have to see people more than once a week because I have a full hour with them and I can give them like a really just like biggest bang for my buck session with them instead of maybe having less time with people and requiring more touch points. So those are a lot of ways that we collaborate with other professionals. And yeah, we have a phenomenal group of physicians that we work with. We've been really lucky to find some really rock stars in the area, concierge physicians who don't take insurance and insurance-based physicians. So we have a really good network to be able to support people with whatever type of setting is best for them. I wish that everybody could experience like the hour one-on-one, but we have really good people in the area that are that take insurance that can provide that a very close experience too.
Yeah, jumping on a little bit of that care gap, sometimes when things become expensive for patients, part of this is validating my own kind of practice. I'm just asking a question to this extent.
Yeah.
One of the things that I say is, let's say someone says even their insurance-based copay is like $50 or even $100, I've heard it, for one PT session, which is kind of outrageous. A lot of times I tell my patients, go at least 2 or 3 times, get that evaluation, start to do some sort of exercise, then take it home. Do you think that's kind of a valid approach? Is that something you do in your clinical practice if someone really can't afford too much but still wants to try?
Absolutely. I think so much of what we do is provide education for people too, where I do that all of the time, actually, especially because we are very thorough and provide a really comprehensive like evaluation follow-up of an overview of your findings, the things that we think are contributing to what you're experiencing, the things we found that are fair game that you can keep training, and some ideas for exercises to continue to work on. So absolutely. I mean, there's even just there's many times where we do almost like a one-off consultation of here's what we found, here would be great things to continue to incorporate in your training to continue to work on what we found today. And then we can meet on even like a once a month or once a quarter basis to check in. We do that all of the time. Definitely not everybody who sees us is coming in 3 times a week. So there's definitely ways to use more of like the skill of the education that we're able to provide for people to help them carry out a program.
And then one of the other biggest questions that someone might have coming into something like this is, hey, if I get injured, do I just have to do PT again? Is there actually, given that we're the Preventive Medicine Podcast, does this actually prevent future injuries? So if I go through this process, do PT, and then start, quote unquote, training as my PT, is this going to make sure that I don't get injured again? Have you seen that in your experience, or what can you speak to that as far as preventive medicine?
If I could prevent injuries, oh, I would be a famous person. That would be amazing. No, the way I describe it to people is, at this time, we don't really have extremely high evidence on anything that truly prevents an injury. What we do know is things like load management and volume management are probably the biggest predictors of spikes in pain or injury flares. When I say that, I mean basically suddenly doing a lot more compared to what you've been doing historically in your training is a pretty good predictor of something that could lead to a spike of pain or injury. So you haven't ran in a very long time. You decide you're going to run again for the first time in 8 months, and it's a 4-mile run. In your head, that doesn't seem like much, but that's 45 minutes to an hour of just jumping around over and over again. That's a lot for a body that hasn't been used to it. So the education component of very often it's this sudden spike in training volume or sudden spike in demand of your body that it wasn't quite used to, quite frankly, being the bigger reason for more pain and injury in the absence of like a very specific mechanism of injury or some sort of disease. So that's a really big take-home point that we want to really hammer home with people. We can't 100% prevent anything from happening, but we can help you develop a lot of strength and resilience to be able to tolerate what life throws at you. And we can create a really solid program that involves progressively and gradually exposing you to more, that is matched to your goals, that has the intensity and frequency and volume that matches what your goals have, to be able to make sure you can at least handle what happens. I get injured too. Like, we all get injured. There's nobody that can prevent injury, but we can become very strong and resilient to tolerate it better.
That is almost exactly it. That's one of the things that I also tell my patients, that, hey, if you do this PT and it's good PT and you kind of really develop a training kind of routine or whatnot, then you can also probably self-manage your injuries better, because probably I'd say 80 to 90% of things that come to the clinic can get better with some basic PT, whether or not they have a specific diagnosis. And if they're just able to kind of tolerate through a little bit of that pain, continue to find ways to move and do things, then they'll get better on their own. They don't have to come and see someone like myself who's going to diagnose them and be like, hey, go do some good PT again. Because while I do like doing injections and things like that procedurally, I don't want to just stick needles in people for no reason. So obviously, some great PT is fantastic. So definitely that load management and being able to self-regulate is a huge part of that.
Yeah, I think teaching people that is probably goes far beyond any perfect exercise selection I could ever give somebody. Helping people self-manage and auto-regulate and learn that, it's not, because what we always hear from people, right? Like, oh, I guess I'm just getting older. It's like, no, you haven't played soccer in 12 years and you joined a league. That's why your calf hurts. It's not that you're getting older. You haven't jumped in 12 years. So people don't see that, though. They don't realize that connection of, we so often societally blame a lot of this stuff on just aging. And it's less about that. It's just the time compared to when you've last done this thing is just getting greater and greater and greater. So the more we can keep these habits throughout the lifespan, the better we can handle stuff, because we're kind of always exposing our body to things.
Definitely. How do you kind of approach the person that's used to PT in the sense of, hey, I'm used to coming in and doing some massage or some manual therapies for such amount of time? How do you kind of manage that, number one? And then number two, can you just kind of talk a little bit about the evidence for things like manual therapies and whatnot, and what their role is in PT? I think that's important to address.
Yeah, absolutely. I think talking about the evidence is helpful, because then it kind of parlays into your question too. We don't have really great evidence that shows manual therapy is much more than a very general transient nervous system inhibition action. Basically just calms you down. There's nothing wrong with that. Calming people down that are flared up, there's nothing wrong with that. However, I would prefer to select strategies that are kind of achieving my two main goals at all time, that drive every single decision I make clinically. Am I doing something to create physiological adaptation? And am I doing something to create psychological adaptation? And quite frankly, for me and the way that I practice, I can't answer that as a yes if manual therapy is involved. The physiological adaptation has to occur with creating enough of a stimulus for tissues to change. There's nothing that happens that is being done to you that is changing your physiology, other than a very temporary nervous system inhibition. Again, can be valuable for some people. I don't think it has enough bang for the buck in terms of, if I want to give somebody the most beneficial hour I possibly can with them, I'm going to get them moving. I'm going to get them in a positive experience with movement, and we're going to be having a good time together. The other thing psychologically is a lot of people kind of become reliant on some of these more passive strategies and think that that's the thing that's kind of what they must do. If we know that most people coming in to see us, we have data on this, 75% plus of Americans do not meet basic physical activity guidelines, which is strength training twice a week and 150 minutes of aerobic exercise. 75% or more at this point do not meet those guidelines. We also know that, as we were discussing, there's a huge relationship between poor metabolic health and the quality of people's tissues that therefore lead to higher incidences of musculoskeletal pain. I don't think I'm doing my job if I'm rubbing somebody on a table when I know we have an epidemic that is that gigantic in terms of lack of physical activity and how it's linked to pain. So that's kind of where my clinical decision-making comes from. I want to be clear that I'm not bashing manual therapy. I think there absolutely can be a place if it's a strategy you like. I just don't think it gives enough bang for the hour that I want to really in that session. My thought process is man, how can I impact this person's physiology and psychology the most today? For me, it's always going to be movement.
Yeah. Is this something you might have someone do maybe before they see you, like while they're in your facility, some like foam rolling or some stretching passively, that kind of thing before they see you? Is that something you might encourage then?
If they want to, and if the training session or rehab session we're about to do would warrant it, like I wouldn't want somebody to stretch before we're about to do heavy explosive stuff because that doesn't really help. If people like foam rolling, I would never tell them not to do it. I would say come in early because I don't want you to spend your money to foam roll. I would rather people just know that they're coming in for that hour of very intentional, curated, individualized program that was entirely created for them. So if people like those things, and I will always refer to other providers that I know maybe do some of these things if that's what they're looking for. But when they're working with me, I make it clear that we're here to move, we're here to make change. And that's the kind of the philosophy.
Yeah, my personal way that my practice has evolved is essentially saying to my patients, hey, look, when I send you to physical therapy, I want you to work on actual exercising, not a lot of these passive things, because those can feel great for a little bit. They can reset it, but that's not what you're going to this person for. They're an expert in kind of translating you to taking you from where you're at to getting you back moving. So I want you to spend your time doing that. If you want to do massage or other kinds of things, either you can see a massage therapist or find like a foam roller, do these things at home. When you go to therapy, make sure you're doing something active because I don't want you to waste your hour, however much time you actually get with this therapist to do just that. My wife's actually a physical therapist, so I know her frustration.
Cool.
She's worked in kind of a lot of clinics that kind of are a little bit more heavier in those kinds of things. That's definitely a frustration of hers, and a lot of people come in and kind of demand it. So I think from my perspective, if the physician starts by saying, hey, this is why you're going to PT, I don't want you to do this, and the patients get an understanding, because otherwise sometimes they go to you and be like, they demand it. And it's like, this is what PT is, and that's just what they think it is.
I love that too. Yeah, if you can set kind of the stage on your end as well, and almost like manage those expectations from the beginning, that goes a long way too. And it's always something where I don't mean any of this like disrespectfully to people who like manual therapy. It's a tool, but I think we just have to be honest about what it is doing, what it's not doing. And I think that's really important for patients too. And it helps them really realize, like, as you were mentioning earlier, the self-management side of these things, and where a lot of our goals are to get people back to their life, like to not feel reliant on something that isn't maybe doing what we think it's doing, or what I think physical therapy at large likes to say manual therapy is doing. It's calming stuff down. That's fine, but that's about the extent of it.
Exactly. If there was, so I'm talking about the transition of care from my end to a PT. From your end, is there anything you want physicians to know, or someone who might be referring to you for, hey, this is how I want you to set things up. This is what I want you to know about what I do. What do you want to say to physicians if you could scream from a rooftop up there?
That's a great question. I think a big thing is that so much of what we do does not need to be very diagnosis driven. And I think the more we label patients with hyper-specific diagnoses, the more harm it does. Meaning, like, once we've rolled out red flags, or if there wasn't a mechanism of injury where we have a structural issue, most people's discomfort and pain and injury is more of a load management issue, is more of a not really training or like existing in life in a way that meets the demands of what they're asking their body to do. Or it's underlying metabolic issues that kind of are contributing to these aches and pains. So I really think a lot of the overemphasis on diagnosis can be harmful for patients to really kind of like identify with this. They think something is wrong with them forever, when in fact it's really just like, well, maybe we just get your glutes a little bit stronger. Like, that's a lot less scary than telling someone they have piriformis syndrome and they're going to die. So I think that's a big thing. Just being a little bit less diagnosis driven when we don't have to be, I think is very important. I think also just the idea of milestones versus timelines in rehab. No human is a textbook, and there's no human that we can definitively say is, well, it's been 3 months after your ACL, it's time to run. It's so much more milestone driven, with good training, good testing, good progressions that dictate whether somebody is ready for a new task or not, instead of arbitrary timelines. So I think those two big things, like setting those expectations, are huge, and I think helps a lot of the fear that people have with receiving a diagnosis, or the expectation of like, well, my doctor said at 3 months I'm going to be running, and they're an ACL patient who's coming to you way later who still doesn't have terminal knee extension. Like, we are so not running. So there is a lot of that kind of milestone versus timeline that I think gets a little bit blurry.
So from your perspective, or I guess the perspective of someone who's doing the therapy, do you care if in my referral I'm putting a diagnosis or not? Because I notice that a lot of times patients do care about what their diagnosis is, because I can't just be like, hey, your butt's weak or your glutes are weak, whatever it is. They want to be like, hey, what's actually wrong with me? So obviously from your perspective, it doesn't matter as much because a lot of things are kind of the same advice, whether you have greater trochanteric pain syndrome or whatever may be going on. The advice is going to be the same. You need to strengthen everything regardless.
Yeah. Well, with being, I mean, direct access, it's very rare now that we really even get a script. So, yeah. And to be quite frank with you, and again, I don't mean this disrespectfully, most physician scripts are just like checking boxes and stuff that none of us do anyway. Like it's just like these very generic terms. So I'll be completely honest with you, unless it's like a post-operative care where there's very specific things that have to be monitored. Most PTs aren't really reading those scripts of like, thank God I know what to do now to check this box. So a lot of it, like, I understand sometimes, of course, like a patient is kind of craving that diagnosis, but I think with direct access and without taking insurance where there is a requirement for an ICD-10 code, so you know what the diagnosis is for reimbursement, we kind of almost circumnavigate that naturally because we don't have somebody coming in saying like, this is the thing that's wrong with me. What we do run into a lot, of course, is people coming in with an MRI report and kind of being told like, well, my doctor told me I have the spine of an 80-year-old and he didn't know how I walked in here. I don't understand why training is what I should do because clearly I'm about to die, right? And that, yeah, I know that just makes you die inside. That is the stuff that's challenging that we have to navigate. I could venture to say you're not doing that to patients, but I would say in our setting, since we are direct access, we get a lot more of like, here's my MRI report. And we kind of have to go line by line and talk about how common these findings are and they are safe and they don't have red flags. So I would say that's more of the conversations that we have.
Yeah, a lot of times patients will come in and be like, someone else said I have a bad back, and be like, you have a back. And then kind of go from there, take out the bad and then explain whatever it goes from. But we talked a little bit about exercise and kind of the selection for exercise just a little bit. Is there any exercise selection for particular patients? Is it just patient dependent, or is general exercise enough for most people?
It's a great question too. I think when it comes to exercise selection, I think it's important to think of goal patterns versus perfect exercise. Meaning, if I want somebody to be a well-rounded human who has access to a lot of different positions and patterns, I want to expose them to all of them. It might be different for what you feel comfortable with versus what I feel comfortable with for like a deadlift variation, for example. But the goal is that I want every human that I work with to be exposed to all of the patterns that they could be training in. So a squat pattern, a hinge pattern, vertical and horizontal pushing and pulling, double leg movements, single leg movements, moving side to side, doing stuff fast, doing stuff slow. All of that stuff, in my opinion, should be involved in every single rehab program and therefore every single training program. So how we select exercise and dial stuff up and down is very patient dependent as well as goal specific. So I think that general exercise, if you're checking the boxes of a well-rounded strength program that addresses all of those main movement patterns, plus some sort of cardiovascular activity, hard stuff, slow stuff, like steady stuff, that's really helpful. Of course, things can get more specific when somebody has a more specific goal or they have a very particular position that's bothersome or they have a very particular movement that they don't currently have access to. That's where we might get a little bit more creative, but it really is, I want everybody to have exposure to all of these patterns. I think of it too, in the typical PT world, like I mentioned, we're taught to just like measure impairments and then treat the impairments. I think that leaves a lot on the table because if I know that I need to do something hard enough to create physiological change, if I spend an hour with somebody and only do the low level things that they can currently tolerate based on their pain, then I haven't really created enough stimulus in that session. So a good example, if somebody has knee pain with a very knee forward squat position, if I only work up to that limitation in session, I'm probably not really changing their physiology. But if I give them stuff that's like hingy and targets their glutes and hamstrings that feel really good, and I can drive a good stimulus there, then I can afford to spend some time working on things that their knee can currently tolerate and build them up. So it really is a more in our practice kind of zoomed out approach of like, what are the things I can beef up for you and give you a good training stimulus? And then where can I dial you back and really focus on the things that we found were challenging for you? And I think that can be achieved in a much more general sense than like, we're going to do this exercise that targets these fibers of this muscle that you're having pain in versus like, let's get your whole joint stronger. Let's get everything that attaches there stronger.
Yeah, I'm dumbing this down here, but essentially it sounds like you're starting at a pretty kind of like more narrow, goal-oriented, specific type of thing for whatever this patient's coming in with, whatever they're unable to tolerate, and then kind of grow from there and then grow that more into a general like physical preparedness type program. Does that sound about right?
Yeah, that's a really good way of thinking of it in like kind of training speak. Yeah, we have some specific stuff, but then the overarching theme, like I want people to train. I want people to know that this is part of your life. This is something that carries with you. We know now, which is cool, like we're getting more people interested in bone density and muscle mass and its involvement in our hormonal health, things that we were not talking about in like the general public before. So kind of introducing these concepts and getting people aware that like, no, this is the thing. This is the thing that you just keep doing and you just keep doing it and doing it and doing it. It keeps getting harder because you get stronger and you have to make it harder and you just keep going. And if we can instill that message, then I think we've won.
I'm going to say right now, bone density is one of the frustrations that I have because in our clinic, we see a lot of like people in their 70s, 80s with compression fractures. And let me tell you that it sucks. If I can't do it, there's one procedure called a kyphoplasty. It's really well for treating that kind of pain. However, if for some reason you're not a candidate for that, your insurance doesn't approve it, there's not really great treatments out there for it. And obviously that's something you can prevent by loading bones starting early. So that's something I'm starting to scream a little bit more from the rooftops now, being on the provider side of it, of being like, hey, you don't really have great options outside of just hopefully this pain starts improving, you can tolerate more load and whatnot, but really it does suck. So it's something I'm screaming from the rooftops. But in general,
we screaming it. We love that. Keep screaming it. That's so helpful. Yes.
Yeah. In general, we talked a little bit about exercise and kind of having a variety of movements, fast, slow, push, pull, and whatnot. I like to have sound bites and like to have practical take-home things that people can do from listening to this podcast. If you were to create kind of a general, rough physical preparedness program that many people should be doing and increase their physical activity like we've talked about, what would you prescribe?
Yeah, I would say 2 to 3 times per week of full body strength training, hitting every major muscle group in patterns that feel that you can load them the best for you. So that might be machines, that might be barbells, it might be kettlebells, it might be all of the above. But if you're hitting every main muscle group in a way that feels good to you, cool, we're happy with that. Then on top of that, daily walking and just daily movement and activity, just general movement, not for the purpose of exercise, is a great thing. And then something during the week a few times to get your heart rate up quite high, and also some things a few times each week to get your heart rate at kind of a steady state base. So it's just like well-rounded training. Build some muscle mass, do cardio that you could kind of have a conversation with to build your aerobic system, do cardio that you couldn't have a conversation with because it's pretty hard to build your anaerobic system, and get your day-to-day activity up.
That's a fantastic way to break it down and kind of dumb it down as well so people can understand it and not take some of those specifics like, hey, you have to get your heart rate to 160 or something, because that's much more difficult. This is a way easier way to put it. As we're starting to wrap things up, outside of exercise, everything we've said, if someone were to ask you how to get healthy, what else do you say to them outside of that exercise component?
Yeah, I would say in addition to the exercise too is like find something you really enjoy doing that's movement based. There's a million options out there. And I think people, we know from any psychology literature, the way people do stuff is if they actually like it. And if you feel forced to do things that you don't like, that's not really going to be a long-term habit. So if you can find a setting that you enjoy, you can find somebody to work with that you enjoy to help the experience be better for you. I think that's a huge win. I have a client of mine, she always says, she's like, no, I don't like this. I just like being here. And you know what? That's fine with me. Not everybody likes training so much that they decide to make it their profession like I did. But if we can create an environment that makes it so people do want to come, even if it's not for the training, then I think that's a good thing. And then in addition to that, I would say keeping your mind sharp and doing things that challenge your brain is just beyond importance. We know that, yes, exercise does have so many incredible cognitive and neurological benefits, but even more so, or not even more so, but in addition to keeping your brain sharp by reading and exploring and being inquisitive and asking questions and changing your mind when new information is presented to you. The things that keep us sharp throughout our lifespan, I don't think we can separate the two. It's so important for our brains to stay sharp, for us to challenge them and want to keep learning.
There's that professor in you talking about neuroscience and psychology. I'll say that's unique. No one has ever mentioned that in the podcast, I think. And my personal little hack for that is two little dumb things. I refuse to use a calculator, and I refuse to use navigation for like general driving. And I think it definitely keeps me a little bit sharper.
Your hippocampus thanks you for that. That's awesome.
We've been talking about screaming from the rooftops a lot. If I could, we'd take this entire podcast, just put it out there, because I think there's so many gems in it. I think it was a fantastic episode. Katie, thanks so much for coming on.